Post-renal failure occurs when something obstructs the outflow of the urine and just doesn't let the urine flow away. From the kidneys. So BPH and benign or maybe cancerous, if I would say prostatic hypertrophy, but most commonly it's BPH enlargement, because BPH is much more common than prostate cancer, will contribute to this. And if the stream of the urine is obstructed, the pressure will start building up and upstream, and then the glomerular filtration rate would be falling down proportionally. Another thing is bilateral urethral obstruction, bladder outlet obstruction, anything that neurogenic bladder, anything that doesn't just let that urine flow from the bladder out or before the bladder. But if we cannot evacuate urine, it eventually will turn into post-renal failure. So these are three concepts you need to know for ever and ever and ever and ever. So let's talk about clinical manifestation of acute renal failure. Of course, oliguria and urea, elevated BUN and creatinine, hyperkalemia, and metabolic acidosis, hypertension because of the volume overload may occur. And basically this is becoming very big systemic disorder, because when we have renal failure, we are not able to produce urine, and all this fluid will be backed into the circulation and cause hypertension. Chronic renal failure is irreversible loss of renal function, and as acute renal failure, it may affect organ systems outside of the renal system. However, in acute, because the things may go bad and improve quite fast, this may not happen. In chronic, we usually see the manifestation in all organ systems. The renal reserve will be lowered, and at some point patient will start experiencing renal insufficiency, renal failure, and end-stage renal disease. All these stages are described and determined using glomerular filtration rate determination. Chronic renal failure can be affecting creatinine and urea levels, sodium and water balance, phosphate, calcium, potassium, and acid-base balance will be affected. So how it can affect in general the other systems, everything pretty much affected because of sodium and phosphate imbalance. The skeletal and bone alterations will occur, losing calcium, cardiopulmonary manifestation, neural function, endocrine and reproduction, and erythropoietin production will decrease or cease. So from here, hematologic alterations will occur. Chronic renal failure can affect immunologic, GI, integumentary systems. Again, protein, carb, and lipid metabolism affected because of the loss of proteins and lipids, and liver will try to compensate and leading to hyperlipidemia. So CFR, will be gradual increase and will be leading to all these alterations. So let's talk about progression of chronic renal failure. And again, chronic renal failure is gradual progression of the disease. It's a well-known fact that diabetes type 1 and type 2 is leading cause of chronic renal failure, and as a sequela of vascular damage, and not just vascular damage, but damage to endothelial lining. Number 2 is hypertension, and also the other is urine obstruction, not to that extent as hypertension and diabetes, but urolithasis and BPH certainly can block urine flow, which is post-renal acute, may gradually turn, or maybe not so acute, but this is post-renal failure that will turn into a chronic renal failure. Other things is renal diseases, pyelonephritis, glomerulonephritis, renal artery stenosis. This is one of the pre-renal sources, and toxic exposure. I didn't mention the sickle cell disease, but certainly this one is worth mentioning, and lupus, and smoking, another gun in your anti-smoking campaign ammunition. So yes, smoking will do arteriosclerotic changes in blood vessels, and the smaller the vessels are, the worse this, the worse they affected. And kidneys have lots of small vessels, and in addition to that, smoking is a great vasoconstrictor. So this leads to chronic ischemia and necrosis. And of course, I didn't mention age. The older the patient is, the more the GFR affected, and glomerular filtration rate reduces. So, and let's look at the numbers here. When we're talking about reduced renal reserve, we're still all right, but your GFR, and again, GFR is a calculated number by Korotkoff formula or other more sophisticated formulas, but GFR, doesn't matter which way we calculated it, but you see steady reduction to half of the normal GFR. So patient may function fairly well at 50% of GFR, but getting to the quarter of the function or quarter of the GFR will be described as renal insufficiency. Failure occurs when it's significant loss of function and GFR is less than 20% of normal, but patients still can function and may have some signs and symptoms of this, but still would be not so affected, especially if they are at this upper range at 20%. But of course, it's very difficult to function for the patient when this rate starts to decline. And end-stage renal failure, when we are already raising the idea or the thought about or consideration about dialysis versus kidney transplant. And this is the whole big, huge topic about this dialysis and kidney transplant. So it's all really to make it more less complex. You have to consider many factors that will be determining what to do: dialysis versus kidney transplant, the patient's comfort, availability of the donors, availability of the matching kidney, genetic makeup, because again, transplant, it's not an easy procedure. In any transplant, it's not like changing the tire on a car. So you just can't get the part and fix it and then it's done, good as new. No, transplant is unfortunately, some transplants may require lifelong immunosuppressive therapy. So this may actually, having a transplant, decrease quality of life of the patient, which may be on peritoneal dialysis or hemodialysis, and versus having the transplant. So this is, to summarize it, this last statement, it's all on case-by-case basis, and it's all really the individualized decision has to be made. Renal insufficiency occurs when, again, GFR is reduced to 25%. Patient will still have mild clinical symptoms, which will be related to mild uremia. BUN creatinine will increase, maybe some mild anemia, yes, again, erythropoietin. And during the stress, this is like, you would say, what that has to do with it? The renal function is impaired, and this is very easy explanation. There is more and more blood circulating through kidneys, and the rates for filtration and the needs for filtration is increased. So the stressful situation will affect kidney function, and it will actually reduce the kidney function. When we're talking about renal failure, GFR less than 20, BUN creatinine continue to increase, oliguria, urine output is just very small, metabolic acidosis can set in with electrolyte imbalances, with hyperkalemia and hypernatremia, anemia becoming severe. Erythropoietin probably shots will be very, very helpful to the patient, sub-Q shots, and uremia that may affect non-renal organs. So renal disorders can be very debilitating and impair quality of life of the patient, and again, this may result in complex disorders and diseases affecting multiple organs. And I just would like to add a couple of words about the prevention of renal disorders, and most of it you already know, but again, diabetes and hypertension are two of the precursors of the renal disorders, chronic renal failure and need for dialysis. And unfortunately, the rates tend to increase. So from your point of view as future professionals in nursing with advanced degree, please don't forget it, that seemingly easy to treat diseases like diabetes and hypertension may lead to the devastating consequences. And I'm saying seemingly easy to treat diseases. Treating those is lots of work, both for patient and for the provider. And from this point of view, obviously you want to get better outcomes, you want to have better outcomes for your patient, and you will try your best in this, and you will have, if you succeed in treating these two disorders, you will prevent lots of harm and lots of damage to your patient's health, and give them or support them or support them in their healthy lifestyle and increase their lifespan and increase the quality of life. And this really boils down to these fairly simple disorders as diabetes and hypertension. And by simple, I really mean there is treatment available and most people would respond to it. And having that treatment available will prevent not only these complications, but also will be saving lots of costs for this patient. This will conclude the lecture for renal disorders. Again, please email me, call me, text me if you have any questions about this. And I appreciate you being such a great audience. And I know I cannot see you or hear you at this time, but you certainly make up for it with your great questions and great attitude towards this course, and I really truly enjoy interacting with you even on that level. So again, please call me, text me, let me know what's going on if you have any questions, and good luck with the test.